Hello, thank you for tuning in. We're at the Grand Rounds interview. My name is Dr. Valeria Duarte from the Adult Congenital team at the Houston Methodist. It's an honor and a privilege for me to have Dr. Laith Alshawabkeh. He's the director of the Adult Congenital Heart Disease program at University of California in San Diego. We just finished wonderful ground rounds with great interest from the audience. Laith, thank you for being here with us.
Thank you for having me today.
We have a lot of questions from the audience, and we'll try to address as many as we can. So, Laith, we were discussing that there is great concern about the early mortality post-transplant in adult congenital heart disease patients. Even though they do better than other patients after 1 year, that first year mark, it's certainly a concern for most centers. So how can we improve early mortality post-transplant in adult congenital heart disease?
It's a great question. So in order to improve the mortality, we have to understand exactly what the cause of mortality is. And I do have to acknowledge that, unfortunately, with the currently available data sets, that we do not have a clear idea of what are the specific causes of mortality. But anecdotally and probably universally among different surgical transplant centers, the common risk factors that we think about are intraoperative mortality, has to do with the technical aspects. And actually this has been published by the ISHLT, a report that the rate of deaths in the first 30 days among adults with congenital heart disease is substantially higher than those without congenital heart disease, and there's a larger percentage of the causes of mortality are attributed to technical reasons.
Correct.
So it has to do with the surgery itself. We also have to think about the ischemia time and the time the surgeon needs to reconstruct the pulmonary arteries in certain cases, and we also have to think about the collateral burden and bleeding intraoperatively, but also bystander organ dysfunction such as the liver among patients with Fontan post-transplant, and kind of creates some challenges in managing these patients who are typically vasoplegic post-transplant. I view these as opportunities for addressing these problems, and I do believe that we can address them collectively.
Okay, yeah, those are great points. Can you expand on how do you work through, what's the process? Because Dr. Alshawabkeh has had a great success creating this transplant program, and we all know that it takes a village, it's a sports team. So how do you structure that team? Who are the members? Do you have meetings? Can you tell us a little bit more about how the structure works and how you put all the pieces together for the transplant team to have that information available when the organ becomes available?
First of all, thank you, but I like to think that I've joined a phenomenal team, and we have an amazing growing heart center and heart failure program as well, and so ACHD came in the right time. Our adult congenital heart disease program, and the way we've opted to do it is to have crosstalk. So we have one of our heart failure colleagues, Tony Uri, who comes over to all of our meetings when we're discussing patients for any type of surgery, including transplant. And the transplant surgeon comes over to our multidisciplinary meetings for adult congenital heart disease. So that gives them an idea of the types of cases that we're discussing, and they contribute from their perspective. If a patient is undergoing high-risk operation, then I do want their opinion and input. And sometimes we do transplant evaluation even before taking them to do non-transplant surgery as a backup in case the patient has a complication. Vice versa. So I do go over to the transplant team presentations when they're talking about our patients, and we co-manage patients when they're admitted to the hospital, also in the perioperative phase. But I would like to put emphasis on planning. I think you can never underappreciate. You can only underappreciate the value of a priori planning for these patients. So we talk about their anatomies. We talk about, at the time of surgery, how much of the pulmonary arteries we need to reconstruct. We talk about, do we do a liver transplant in addition to heart transplant? We look at the anatomical challenges and the patients have had to go through, such as collateral burden. And when exactly do we close the collaterals before transplant? And also post-transplant, how often do we look for these collaterals to eliminate them? Because they do grow after transplant, at least some of them do. So these issues, without crosstalk between adult congenital heart disease and heart failure, are going to be very difficult to achieve. And so we come up with a committee document that goes in the patient chart that everyone is able to see, so that 2, 3, 6 months after we discuss these complex patients, people can go back to this detailed document when an organ becomes available, and they're able to review it.
Oh, fantastic. From a heart transplant team perspective, do you have a point person, one physician that takes care of all the ACHD patients, or is something that all the heart failure teams takes part of?
So it depends on which stage of heart failure. So we have a protocol where if a patient has certain risk factors for heart failure, such as being on a high doses of diuretics, or if they've had a recent hospitalization with heart failure, or if they have systemic ventricular dysfunction. I do have them at least meet with one of the heart failure docs. Again, Tony is our kind of sort of designated, and he has interest in ACHD as well. So we see them together, and we come up with a long-term follow-up strategy. It can be very challenging sometimes, and I would say often, on a personal level, when you're talking to our patients about, I think we should consider transplant in the future. This is a major news that we have to basically plan for and work towards that. And what we want to avoid is, acute critical situations where there's no time to kind of basically deliver the message in a graded fashion.
Oh, those are great points. And tell me a little bit about the post-transplant follow-up, the immediate post-transplant and then longer term. How do you team up with the heart failure? Do they take over the care and consult you as needed, or you work together for a certain period of time until you're out of that window where the collaterals can be an issue? And how do you work through that?
So that's a great question. So generally speaking, depending on the anatomy and any residual lesions, if someone had a hypoplastic left heart, so those patients will continue to have coarctation type phenotype. So those patients I tend to follow long term, albeit not as frequently if they had the Fontan. In terms of the collateral question, it's a balance. Okay. Post-transplant, these patients are on medications that affect the kidneys. So often we're not able to do a CAT scan or a cath to address the collaterals. And frankly, most of the time it's not needed had they been addressed at the time of listing or before listing. But generally speaking, at the 6 month to 1 year mark, we do a study to evaluate the burden of collaterals.
An invasive study, you mean?
We start with a CAT scan because then you can plan out your cath strategy and not have to go and deliver and give a lot of contrast to find the collaterals.
Well, thank you, Laith. We're going to try to go through a few more of the audience questions. So, are there any anatomies or physiologies that you would not transplant? That's a great question.
To rephrase this, are there contraindications anatomically or physiologically for transplant? I would say most of the time not anatomically. And what we worry about in terms of the physiology is it a little bit too late? So if there are more than 2 other organs that are affected, then it becomes challenging to list these patients. And we also have, along the same lines, we do have to think about advanced care planning and really understanding what the patient wishes are, informed kind of decision making.
Perfect. We have another question. Fontan patients who have liver disease but got only a heart transplant and did not get a liver, does the liver disease progress post-transplant or gets better?
I don't think this has been looked at systematically, and it's a great area of research. But anecdotally, again, we just don't, you don't see worsening of the liver status because obviously you decongested the liver with a new heart unless there's a graft dysfunction problem or if there is risk factors such as drinking or other causes for liver dysfunction. But generally, we don't see progression.
Wonderful. Should we list certain patients with minimal symptoms knowing the natural history of certain anatomies? And I think you covered some of that during ground rounds.
That's again finding the right window of when to obviously you don't want to list patients too late because their perioperative risk is high, but also you don't want to list people too soon. We all know the limitations of heart transplant. You're not, this is not the ultimate treatment. There is graft,
correct,
lifetime that you have to think about and the average life of a graft. So no, if we think that a patient will accrue better survival, then we go ahead and list them. But if they don't, then we generally do not list them.
All right. This is a great question. What is the role of non-ACHD cardiologists in managing these patients given the shortage of ACHD specialists?
That's an aching point of the shortage part. Honestly, let's face it, most adults with congenital heart disease are managed by non-ACHD providers.
Yes.
And there is no substitute to collaborating with them and educating community cardiologists. We do this frequently as well. But also, I know different models around the country where there are champions of ACHDs among general cardiologists who have not had specific training, but have developed some interest in managing these patients. I think of it as a very symbiotic relationship where identifying the triggers for involvement for an ACHD specialist is at the center or the core of this relationship.
And have you looked into a shared care model, like some transplant centers have working with cardiologists in the community and alternating visits with good communication? Have you looked into that specifically for our patients?
So we do this routinely. We get a referral, a patient needs an operation or a complex cardiac cath or an intervention. They get that done, they see us for follow-up, and then we determine long-term strategy. And again, you have to also gauge the comfort of the referring doc of how frequently they need to follow the patient. And some they want the patient to be followed entirely with an ACHD, which we do. But a large proportion of cardiologists do like the idea of a shared care model, and it works well for patients.
That's the priority. We have time for one last question. With the growing population of ACHD patients with advanced heart failure and limited donor supply, are permanent mechanical support devices being developed to meet the needs of these patients with complex anatomy?
The answer is yes. There are many institutions that are working on different designs of support devices, and I think the majority of these designs are geared toward the Fontan circulation. But obviously there has not been robust clinical trials yet. But this is something that we eagerly look for in the future. But I just have to mention also along those lines that some patients with specifically the Fontan circulation may have a cardiomyopathy type phenotype where the primary cause of heart failure is severe ventricular dilation and dysfunction, and they have no Fontan pathway obstruction or residual shunts. And those patients, you could theoretically actually consider them for mechanical circulatory support that are currently available. I know there's been a case report about a patient with Fontaine who had an MCS. And we've recently had a patient who had a mechanical support device, a VAD, for almost 9 months.
As a bridge to transplant?
As a bridge to transplant, a dischargeable VAD, before he underwent transplant. So.
Those are wonderful points, Laith. Thank you for your insight. I had the pleasure of training with Laith in the Boston program, and I look forward to future collaborations.
Thank you so much for having me.
Our pleasure. Thanks for tuning in, and until next time.